Welcome back to another episode of Care Transitions Today. This healthcare podcast is focused on case management and transitions of care. The podcast is presented by the American Case Management Association, and I'm your host, Deb McElroy. Today, we're going to continue our discussion around innovation in case management, and we're going to be discussing a successful team approach in reducing COPD readmissions. I'm delighted today to welcome Thomas Rhodes. He is the Director of Operations at Houston Methodist West and Houston Methodist Continuing Care Hospital in Houston, Texas. Thomas has a wealth of experience in respiratory care, the last decade spent in leadership. He started his career as part of a critical care transport team, and he oversees more than 100 staff for the two locations that I mentioned, and just a highly collaborative team approach. And we're happy today to hear about his project where he was collaborating with case management. So Thomas, welcome. Did I miss anything in the introduction?
No, that was a great introduction, and thank you for being so kind to me.
Well, good. Well, we're excited to talk about this because the project was really a collaboration with case management. Obviously, lots of folks listening interested in that. So can you talk about the project and your program and, how a respiratory therapist-led education program really impacted acute care readmissions for COPD, something that folks are really worried about?
Yeah, thank you. So around about 2016, I was approached by my one-up, who was the CNO of our hospital, and tasked with somehow coming up with a plan that was collaborative in reducing the overall readmissions for COPD. And at the time, I was a service line leader for pulmonary, which kind of fell under my umbrella. And case management, our director in case management, Alma, who's wonderful, actually was tasked with all the other readmissions. So she had quite a bit on her plate. So I was more than happy to try and help her out there and also really make an impact in something I believe that was really dear to respiratory care, which is COPD. When we first started, we had a number, it was in the low 23.4%, somewhere around there, readmission rate for COPD. And at the time, I believe national average is right around 20.8%. So we were going to be in that penalty area for CMS, which you never want to be there. However, sometimes, unless you really take the task at hand and focus on it, you will be there, as we were, right? So the first thing we kind of identified was, what do we want to accomplish with this program, right? Not only decrease numbers, but also have better patient outcomes, right? Just from our experience in studies, we see that patients who readmit to the hospital less have better outcomes managing their disease process, and also, better home life balance, right? Patients are more happy at home than in the hospital. So it's our goal to service them, to care for them, give them the best outcomes possible, but actually able to sustain it. Not just, okay, we turn you around, you're okay with your disease situation right now. However, you'll be back in 3 weeks, right? So through a lot of research, we found that most patients actually return to the hospital for COPD within that 3 to 7 day window, right? Whether it's not meeting the home equipment needs or medication not being filled, so many different things. So we determined early on that it's going to take a village to really accomplish this, not just respiratory care or case management. We've had several stakeholders, 7, 8 stakeholders that we identified that would be really crucial for the success of our program. So starting out, the first person I kind of reached out to was our pulmonary leader. So we had a pulmonary physician, Dr. Ahmed, who championed this for us. So we can then have a voice on our med exec committees and things like this from a physician perspective. So he was willing to do it, joined, really tapped him for a lot of information in regards to how those patients are treated once they leave the hospital in the outpatient setting, right? Clinic follow-up and things like that. And the other key stake of that was the emergency department. So we identified one emergency room physician that would champion with us, and that's where Dr. Wang came in. We approached him, they're so busy in the ED. So, he was kind of hesitant about the task at first, but, we explained to him, we wanted to make sure he was part of our pathway that we developed and our process map, because most of these patients, they use the ER sometimes for physician visits. So we needed to make sure when they were admitted to the ED, we had a support team there for them to make sure we get them the resources they need, the medication available, things like that, a good med rec, and get them turned around. So from a physician perspective, it was pretty much pulmonary and ED medicine. The third physician partner we then championed down the road was actually our internal medicine physician for our med surg department. Because a lot of times, the internal medicine folks, they'll actually care for these patients and continue the care plan while they're in the hospital as inpatient. And then their physician will take back over their PCP or pulmonologist once they're discharged. So we approached our internal medicine physician and then said, from that standpoint, how can we develop a 1, 2, 3 day pathway, right? 2-day pathway for our observation patients, 3-day pathway for our admitted patients, because we want to make sure that we're checking in every day, checking all the boxes that they were progressing to where they needed to better have an outcome in 3 days, which is about our average length of stay, a little over 3 days, 3.2 days for COPD patients. So we wanted to make sure on a third day, all the boxes were checked as far as, whether you needed a new oxygen concentrator at home, a new CPAP machine, their medication ran out. It was so many different things. Medication seemed to always rise to the top. We're trying to make follow-up appointments for these patients 3 to 5 days post-discharge, right? So many patients, after they've been here for 3 days, they do not want to go back to the doctor in 3 days, right? Or 5 days. So really having the patient to understand, we need a good care plan for that you can follow. And the only way you'll get that is in a follow-up visit, which, we realize that most of the patients, they do come back in 3 to 5 days. And that's our golden window, that if we can get you to 7 days, you're probably going to last at least the 30 days, right, before you get the visit. So we want to make sure we're able to get the physicians on board. So when the volunteers call, right, they have preference for scheduling, right? Hey, this is Vivian, the volunteer from Houston Methodist West. I'm calling to schedule a follow-up appointment for Ms. Smith, who is a COPD patient, right? Oh, wait, Vivian, we'll get that schedule right away for you, right? And so you wouldn't have the normal 4 to 6 week wait for a follow-up appointment. So that took some work as well. That took us about 3 to 6 months to really get those folks, those physicians on board with that. But once they did, we brought the data back to them and actually showed them the readmission rate of patients who, one, had appointments scheduled prior to leaving the hospital, and then 2, patients who actually attended the visits, right? And just kind of give you a peek into those numbers, our readmission rates for patients who were just scheduled, not attended, the follow-up appointments were about 6%. Those patients who actually attended the follow-up visits that was scheduled was 0% readmission rate. So that then further validated us to bring this back to the MedOnc committee and let them know, hey, physicians, this is actually what works. We really appreciate your assistance and your belief in us, but we want you to see the results, because what you're doing for us, right, is priceless. So we really needed to further build upon that relationship that we were having with our PCPs and folks in our physician organization. So that part there was really, really important for us.
So I just a couple of clarifying questions, because this is obviously you brought lots of stakeholders to the table. You had a number of physicians, case management, pharmacy, outpatient setting. So did you have, it sounded like you started in 2016. Did you have a formal launch of this project after you brought these different components, that because it sounds like, you got some really good outcomes pretty quickly. So I'm thinking about the folks listening. Can you talk a little bit about what the timeline looked like, or, that process of sort of identifying those interventions that you're talking about?
Sure. So around about May 2016, we had monthly readmission meetings already. So with this focus on COPD for myself, we kind of broke out to a subcommittee that met biweekly. Initially, we met biweekly for, I would say, at least the first 12 months. And with that, the focus on that meeting was really to identify stakeholders, get them to the meetings, develop our care plans, right? Develop our process maps, and then really get some data done with education material. So we developed our own education material here. We have a booklet. It's about a 22-page booklet. It might seem excessive, but actually, we really took into account our audience, right? So most seniors are visual, right? So we wanted to make sure there's a lot of visual components to that. Really, really straightforward wording, right? And that was a big component. You know, when we first started it, I think it was a little too high level, right? So that's where our PFAC committee, our Patient Family Advisory Council, came in, because we presented to them one evening, and that group consists of former patients and family members of former patients. So the patients will actually go through it every day. We presented to them, and they had a blank look on their face, right? They were like,
"It's too much."
Well, what does this word mean? What is this word, right? So that was great feedback for us. As medical personnel, you know, we have so many acronyms and this and that. You really need to have it in layman's terms. And if we didn't get that feedback from them, that was critical. So we went back, brought the book back to the drawing board, kind of modified it quite a bit, shrunk it a little bit, because it was about 30 pages in the beginning. We shrunk it down to 22, put some more pictures in there. We put a stoplight in there, which we call our stoplight, red, yellow, green. If you're in any zones, this is what you do. So we didn't just want education. We wanted to actually, what intervention with each condition, right? What do? You call your physician. What do? You go straight to the ED. What do? Right? You increase your medication frequency. Because we thought that they would really, understand that best. So we brought it back to them. They might have gave us one or two more suggestions. We kind of tweaked those and had our final product. So, with the education material, it was important because we needed the patient to actually take something home, right? And there's all kind of different education material out there already, Elsevier and different ones out there. But we thought we needed to develop our own to really personalize the challenges we were going through here at Houston Methodist West. So next to that, we actually needed someone to then present. Who actually educate the patient? That's where those FTEs come in. How do you get more FTEs, Thomas? Right? So we thought about it and we came to the term, who better to educate a COPD patient and respiratory therapist? So for us, we first started our program. We had what we call lead therapist shift supervisors who actually, they really didn't see patients on a daily basis. They more, manage the shift, the task every day. So they had a little time we built in for them to then educate however many patients we had a day, 3, 5, 7 patients, to really follow those patients through every day. So they gave us feedback and through the program, it really made a big impact. And not to kind of get ahead of myself, but further down, we really identified that a dedicated person to that really will have the best outcomes with that, right? But in the meanwhile, when we first started with the respiratory therapist, the lead therapist, again, we saw, a reduction in numbers when they were finally going there every day, Monday through Sunday, to see patients. We first dropped, I think it was down to around 12% within the first 90 days, 12% readmissions. And kind of from there was pretty much where we sustained the first year, all the way through towards the end of the year, where we actually got down to 0% for 2 months, which kind of, wow. We ended at about, it's about 14% in 2017, because January was still pretty high. January, we're up to still about 24% readmission. So we steadily decreased it over the next 12 months. And just with that, we were in the top quartile for Vizient. That's one of our measures in the organizations we belong to there. So that was our goal at first, right? Top quartile. The trouble with that is, when you have such early success, where do we go from here next, right? So we were about 14, 13% top quartile. So our goal was to just sustain, right? How can we sustain this? So we then tried to, again, always try and tweak the program to make it more efficient and better for the patient, right? Like I mentioned with the book, right? It was too complicated, too cumbersome, and we kind of went back and modified that. So we always like to try and get feedback from patients real time as much as we can.
So I'm going to just two questions really leap to mind as you're talking about this. So you've got the educational information for the patients and the way you tweak that. At the same time, you were developing with your stakeholders the clinical pathways. So you did those probably both in parallel. It makes sense to me to have dedicated folks, but in this contracting sort of environment economically, how did you create an ROI for a dedicated respiratory therapist? How did you say, okay, it's going to shift from the supervisor person as sort of just an ancillary task to somebody who's really going to, there's got to be a return on investment. My assumption is that's with the reduction in percentage. Is that right?
Correct. So, we looked at two things. First of all, when I mentioned our first average length of stay for COPD patients was about 3.2 days per stay inpatient. And we're probably doing about maybe 76% of the patients who came through ED were admitted at the time, right? And that was one of our focuses. A lot of the metrics we used was admission rate and then length of stay. So when we first dedicated the person, we were able to then convert our admission rate all down to about 32% of COPD patients. And the reason being for that was the process map that we developed that started in the ED. We had our medical director, Dr. Edwards from the ED. We visited their physician meeting probably 6 months straight, every month for 6 months, to really educate the physicians on what we were doing, right? What the process was. Hey, if we have a COPD patient in the ED, call a respiratory lead. They're going to come then visit and educate that patient for you, and they'll help with the care plan of that patient, right? So in a way, it took something off the physicians, but at the same time, they had more support, right? So that was a pretty easy win after about 3 months when they said, wow, this is a lot easier. I can now call Susan and she'll come down and do half the thing I was doing the whole time, right?
Yeah.
So with the admission rate being decreased, and then our length of stay went to about 2.1 days from 3.2 of inpatient admissions. So, with that, and our finance folks, they kind of ran the data and everything for us and really saw the savings that we had between not having a patient here an extra day, right? Which, everything's bundled payment now. So, the savings in that. And then also reducing the admissions, and which again, the readmission. So no penalty from CMS now, right? And then again, with the hospital reduction in length of stay, the numbers kind of spoke for themselves. So that, I would say, that's probably the two biggest indicators that we used to validate and justify that position.
I think there's a lot of folks really interested in that piece. So that sounds good. So you had, you're talked about having that education for the patients, and I'm assuming the family as well, and you've got your outpatient folks. So is there other things that you thought about as you were trying to, it sounds like you were actually on a education mission all the way through internally and externally. So any other partners from the community that you engaged?
Well, we engaged a couple other external partners. We have what we call a clinic, a non-resource clinic, a couple here in the area that we actually partner with and came in, because the other readmission caveat, if you will, are those patients who are non-insured or don't have pulmonologists or PCPs, they use the ED for their physician visits, right? Which is never a good thing. So we partner with, we have an organization, Christ Clinic, here in our area that's a great partner with us, where we can actually refer those patients before discharge. This is going to be your follow-up, right? They have resources for you to help you. I mean, they help with everything from medication to housing, you name it. So that was a very big community partner. And I would definitely strongly suggest really reaching out to your community to see what resources there are to be able to utilize those, because in an acute care setting, it's hard to manage a patient for 30 days when they're only here for 2 or 3 days. So you really need someone else to help you along the way, that journey, whether it's a physician organization or a not-for-profit clinic like we have here. But it's really important to identify those resources within your community.
That makes sense. And I know you talked a little bit about little shorter pathway if you've got an observation patient, but um, anything else that was unique to the patients that you have going to observations in terms of the resources that you had to dedicate, or do they get handled in a very similar way to the inpatient folks?
Well, observations, our whole goal is, that 48-hour window. Really, our observation goal is 24 hours or less, but we do have 48 hours. So we really have a therapist really hit home with those folks, meaning they see them immediately in the ED and they follow them up to our observation unit and they see them every shift, make sure their medications are on time, they have the right medications ordered. We're really setting those folks up to be discharged from an observation standpoint, but with all the resources they need. So our clock is kind of narrowed, right? It's narrowed down to really 24 hours, because when you get to the last, their discharge is probably an 8-hour process. You might need a ride home or anything. So we're still looking at that 48-hour window. But we have a greater focus on those observation patients because the physician group we have here is amazing. If they actually put the patient inpatient, they need to be here. So we need to make sure, whether it's a 2-day stay or a 5-day stay, that they're okay when they leave. So we really focus on those observation patients, the in-betweeners, who really just had an exacerbation because their BiPAP CPAP machine didn't work anymore. We want to make sure they're turned around, they're back to baseline, and then have the resources they need to go home. So we really focus on those with the pathway. It's a 2-day pathway we have for those folks, meaning we have about 20 to 22 boxes we check, everything from O2 baseline to a 6-minute walk test to make sure that if they needed O2, they qualify for it, they can get those resources. Make sure their medication is there. And one thing I left out, who was a great partner of ours, we actually had a pharmaceutical company, Sanovo, right, who was the manufacturer of Bavana, which is a maintenance drug, which is usually given every 12 hours. We had a great rep at the time who actually gave us coupons for free medication for 30 days. What that allowed for us to do and kind of get to the pharmacy aspect of it, we have an internal Walgreens here on our campus who do what they call a meds to bed program. So once the physician writes for this 30-day order for Bravana, we'll send it to the pharmacy. The pharmacy actually delivers to the bedside of the patient. No cost to the patient. And what that does, that gives us 30 days to get that prescription and the resources set up for that patient so they can continue the therapy after 30 days. But the initial 30 days will actually be taken care of. And that was, one of the challenges, because if a patient comes and they don't have transportation already, picking up a prescription is not a priority for them once they leave and they think they're back to baseline. But then they're back in 5 days because they didn't take their medication, right, on regimen. So that was a big part of our program as well, that med to bed program and our pharmacy involvement with Walgreens and our pharmacy department here, to really, again, get the resources the patients need in a timely manner, where they're not at home, they don't get in trouble, and they come back. And one of the later components of that is the therapist. We do follow-up calls, right? It's the same therapist that educates them in the hospital that calls them at home. It's very important to establish a relationship, right? They want to let you know, hi, Deborah, I'm Thomas. When you get home, I will give you a call in about 3 to 5 days, so you can expect to see this number on the caller ID, right? So they know you're not calling for a bill or a telemarketer, right? You're actually calling genuinely to see how they're doing and if they need anything. So day 5 to 7, the therapist will call them. How are you doing? How are you feeling? Were you able to attend your appointment, right? And that's where we continue to tick our data. Were you able to attend your physician appointment? Yes, no. We'll check the box. Yes. Did they answer all your questions for you? Can I help you out any? No, right? If not, well, can we get it rescheduled for you, right? Or what can we do for you today? Things like that that a patient doesn't get when you go home, right? You might get a robocall or something, but it's rare that you'll get the same caregiver that you had in the hospital in an acute care setting to then follow up on a phone call with you. And it's amazing how many stories that the therapists tell me they hear when it's kind of like a counselor, psychologist, and respiratory therapist, because, you made that connection, that bond. So now you're a friend, you're an asset to them, right? So they really open up for you because you develop that relationship so you can really make headway in further education. By no means are we 0% readmissions, right? But when they do come back, they know they're going to see the same person the next time they come. So they'll say, well, I don't want to see you again, Deborah, so I'm not going to be back for a while. So I'll make sure I have everything taken care of. But the follow-up calls are very important because, it continues to allow us to keep the progress of how the patient's doing and if any needs arise in the meantime.
So Thomas, I mean, I do think those relationships, right, that enhances compliance, it has to. I know from a case management, because so many of our listeners are really in that practice setting of case management or transitional care, et cetera. So can you talk a little bit about how you coordinate with those folks? So you've got, the respiratory department doing heavy lifting here, right? And you've got case management who needs to check in on potentially some of those other needs you were talking about, including transportation. So how does that work for you and your program?
Yeah, great question. So case management and social work here, kind of under the same umbrella. We have, an EMR, which most hospital systems have nowadays, Epic, which we're allowed to do real-time consultations. So we'll consult case management if they need DME equipment, right? We'll contact social work if they need housing issues, things like that. But we'll put it in a computer because we track it and it needs to be in order. But really, the relationship with the therapist to call, hi, Deborah, I have this patient here whose CPAP machine broke. Can you come see him right away? Sure, I'm on my way, right? Those folks in the case management department are intricate to doing and completing the circle for us because I can't order a piece of equipment myself as a respiratory therapist, right? So I need that partner to be able to, hey, meet this need immediately. So then we can get the ball going, the patient get discharged home with the equipment and tools and resources they need to continue to reduce the length of stay, but also reduce the readmissions because now we've solved their issue of their concentrator machine not working for the last 6 months, but them just getting by, breathing room air, right? So those folks are really important for us and really continue to give us feedback after they've seen the patient and talked to the patient. Hey, they really don't know how to use their medication. So can we do some teaching on inhalers, right? Things like that. So they're a really good partner for us here.
That's great. You talked a little bit about, your data and impressive results over 2017. Can you talk about the success and challenges you've had since that time? And I just have to say, I can't imagine what the last 18 months because your resources had to be stretched incredibly thin, right, to say the least. So I know in our podcast, we've done a lot of discussion about that. So can you talk about what that looks like today in terms of, just outcomes and where you're focused?
Yeah. Again, kind of just to continue on that, 2017 was a good year. 2018 was an amazing year for us. We were number 7 in the country. We were right below 10% in readmissions for COPD, which is kind of unheard of for the size of the hospital we have now. So gold in 2018. So we moved to 2019. So 2019, we continued on. We were still chucking, maybe 12%, 11%, 13% range. Towards the end of 2019, we started seeing an uptick. We got to 17, 18%. December, January of 2019 going into 2020. And as you said, when March hit, it was really a challenge, not for the number of readmissions, but for the number of overall admissions, right? Starting in March, we kind of shut down a lot of elective things and only the sickest of the sick are coming to the hospital or COVID patients. So what that did for us was we were averaging, say, 15 COPD admissions a month. We were down to like 2 or 3. So when we get one readmission, it really hits us, right? We're really 50% readmission rate for the month or 66% instead of 10%, 1 out of 15, right? So our challenge was, how do we really let patients know it's still safe to come, right? Before they get to the point where they have to be hospitalized for an extended period of time. So, our overall organization did great marketing, with, hey, it's still safe here, right? We're safe. The staff is safe. And probably August, September, around that time, maybe 6 months into COVID, we kind of saw a rebound on patients admitting, patients coming into the ED for other things, right? CHF and COPD and pneumonia and all these other things besides COVID. So that kind of helped our numbers because we were up to about 22, 23% for about 4 or 5 months last year. So it was a battle to fight and get that number back down. So I would say around October last year, we really refocused our energy. Once we got over the big hill of COVID and we didn't have a therapist maybe taking 2 and 3 times the normal load that they would, and we can dedicate that therapist again, we saw an immediate impact in October. Towards the end of last year, we were really focusing, got the readmissions down. So I think we had 2 out of about 30 for the last quarter of last year, which really helped us then to reach our goal for the year and get under the top quartile again. And this year, amazingly, we've had fantastic numbers. We're probably right now about 8% for the year. And that's all the way through end of April, because the data always lags, right? You need at least 30 days plus 30 days. So end of April, we were about 8% year to date, which is fantastic. That's actually the best numbers we've had since we started the program in 2016. And I really think it's to the dedicated therapist that we have, that she's been in that position now for, I would say, about 9 months, and really able to develop those relationships, right, with the case management folks, with the physician offices, things like that. So they know who the person is, the go-to person, if they have ever questioned. So I really can't understate the dedication of an FTE, whether it's a respiratory therapist or a case management or a nurse, to have that dedicated person to really manage this program. Because when we looked at it before, we had a CHF person, we had a heart person, we had a total knee and hip person, but we didn't have a pulmonary person. So it was really important for us to dedicate that person there to have the outcomes we wanted.
That is, I mean, just congratulations, really awesome results. So if you're talking to folks who are thinking, what are the key things to do? Obviously, that dedicated position sounds like, thing number one. Can any other things of someone saying, yeah, we want to make a difference and an impact? Any other key things that you tell them, this is where you need to start?
Yeah, kind of going back, I really start with getting those key stakeholders, right? Getting your pulmonologist involved, getting some education material that you're comfortable presenting and the patients can really understand it, and then go back to it whenever they need to at home, right? And I mentioned before our stoplight, our red, yellow, green stoplight is very important for them to know what zone they're in, and then again, what action to take, right, with their current status is very important, because this way, just because they're short of breath, they don't run to the ER. They know, okay, I need to take a PRN medication, or I need to increase from Q6 to Q4, things like that. So stoplight, education material, all those things are very vital to having a successful program, in addition to the dedicated staff. For us, we didn't start out with that, right? It's kind of like that prove it theory, right? You have to prove the numbers first. So you do have to somehow, it's going to be tight, right? Make some sacrifices in the beginning to say, hey, team, I need you guys to buy in. You're going to have a little more work in the beginning, but I promise it'll work out in the end. We did that for years, 2 years or so, 3 years before we finally got that dedicated person. And now it even furthered the results, right? So it even validates that position even more. So, we're in a very fortunate situation to be able to do that and have the leadership, executive sponsorship to take care of that as well.
Well, that's great. Well, as we're wrapping up, I just, would be interested in final thoughts from you. I mentioned to you before we hopped on the podcast, I just, as I've read about some of the initiatives that you're leading and really the teams that you're leading now, collaboration seems to be the word that was underscored every time. So just personal thoughts that you would want to share with our listeners I think overall on how you drive something that is going to take some time to get up and running and yet has the opportunity to make such a big impact.
Yeah, so it's something where you have to have little wins, right? Getting buy-in is one of the most difficult things for a change in health. Change is not easy for anyone first, right? No one loves change.
Right.
But especially when you're dealing with physicians like herding cats and oh my gosh, getting this discipline involved to work with this discipline and this other discipline who never really got along before. And that's why it's really important to get that key stakeholder out of each of these disciplines to help you lead the change, right? Yeah, and I still can't mention how important it is to get that physician leader, because physicians listen to physicians, right? So when we have physicians presenting, we had physicians volunteering to present this data at their meetings. I was like, well, I'll go present. No, I got it. I'll present. They were just ecstatic and really proud, right, of the accomplishments that we did. And they would say, hey, I was a champion on this one, and look at our success. And the other physicians were like, wow, maybe we need to do that in cardiology. Maybe we need to do this, in surgery and things. So really getting those folks to buy in, to be champions for you, cannot be stated enough. You want to get your desired outcome from any of these tools and initiatives that you're going to use, really get the buy-in. And every time we got to win, right? Every time our readmission rate was below the top quartile for the month, we made sure we shouted it from the rooftops, right? Hey, we're at 14% this month, guys. Great job. Hey, and every win. Hey, Mr. Cooper, he didn't come back this time, right? You have the frequent flyers. Every hospital has at least one frequent flyer that comes twice a month, regardless of what you do, right? Just love you so much they want to come. So getting those folks and to mention a small battle real quick, we had a patient who was one of those frequent flyers, and we had a gap in our closed loop, if you will. It was the ED. He would come to the ED, and the ED physician, he got a different physician every time. So he did his spiel, and the physician said, oh, okay, well, we'll admit you, right? So then we had to circle back really with all ED physicians, hey, and not put a poster on the wall of this guy, but you have to let him know, hey, if Mr. Smith comes back, you need to call us immediately, no matter who's caring for him, so we can get him, turned around. So you'll have challenges like that along the way. And then you'll get over that hurdle, and it'll just be that much more rewarding when you really get it done in the end to see this. And I just can't say how proud I am of my staff and my team and our collaboration here, where we get to go present this data nationally every year for like the last 3 years and just bring pride to the department and organization. So it's just an honor.
Well, that is great. And truly, congratulations on making such a difference and such an impact. We appreciate it. And I appreciate you joining us today to share with all of our listeners what this innovation has meant to you. So thank you, Thomas, for being my guest today. Join thousands of your peers who have made the decision to further the connections, learning, and knowledge afforded through ACMA membership. Take advantage and engage in your local ACMA chapter. You can gain access to insights and professionals in your area by joining one of over 30 ACMA chapters across the country. All of this available exclusively to ACMA members. Visit www.acmaweb.org/membership to learn more. Again, that's www.acmaweb.org. For our listeners, if you've enjoyed listening to this podcast today, please leave us a rating and a written review so that we know what you think. Thomas was a great end of season 2 guest because this innovation has made such a difference. So we encourage all of our listeners. There are 16 episodes in season 1 and season 2 with leaders just like Thomas Rhodes, who have made a difference and who have shared their different perspectives and their innovative leadership through COVID-19, which was the focus of season 1 and through many other of the challenges that our health system is facing today. So this is the last episode in season 2, but there's more to come. Please subscribe to the podcast so that you're notified when new episodes are available. And until then, thank you for listening, and thank you again, Thomas Rhodes, for joining us today.